For him, we don't require an introduction, I think. No introductory slide for.
Anyway, I would like to thank you, dear chairpersons. Thank you, Shruti. It's a very thought-provoking talk that you have given. Not just because the interestingness, but also you have raised a serious question about testosterone. In fact, me and Anbu were looking at each other. Yeah, what she said is right. And I think this needs a lot of discussion. Probably tomorrow, in the Jugalbandi tomorrow, we are going to have it and we can have this question to be answered. And probably you also can contribute in correcting that probably. Good afternoon, everybody, and then thanks for coming. Today, as Dr. Panneerselvan's favorite actually. This is actually, probably you would have spoken regarding this topic rather than me, I think. His favorite talk. Anyway, basically, I just wanted to look into the prevalence and management strategies that we can have. Now we can see that nowadays the fatty liver, the so-called NAFLD, is renamed as MASLD. It is very sensible to say MASLD, but probably in the next few slides I have not changed the it still has NAFLD. Please excuse me for that. But it is NAFLD, otherwise now it's called as MASLD, indicating you can see that the metabolic dysfunction, you see that MASLD, metabolic dysfunction associated steatotic liver disease. Okay. Now, it is not just having a fatty liver. If you want to call it as an MASLD, you need to have at least 5% of the fat in the liver, and otherwise also you should have at least one cardio-metabolic risk factor, such as elevated triglycerides. This is a very, very important thing. Friends, definitely in our practice, is most of our type 2 diabetes, we see triglycerides slightly elevated. No, it may not be 400, 500, 1000, some very rarely we see that. Maybe about 5 to 6 out of 100 patients we see more than 500, 600. But most often we see 250, 220, 180 like that, that don't ignore that. That's the reason why I'm talking. Now you got this is a very, very typical Indian phenotype. Why I'm talking about more about is that you look at the low HDL and elevated triglyceride. These are the two things, and it's a very, very Indian phenotype. Even Dr. Mohan was speaking during his oration about this. Either diabetes or pre-diabetes. Obesity, of course, it is increasing like anything. And tomorrow, don't miss that session of almost about 1.25 hours on obesity. The way enormously it is trending. I would like all of you to look into that aspect. It is very, very severe problem we are going to face in future. And high blood pressure. Any of these things should be having one metabolic factor. Now this is why I am talking. You can see that worldwide incidence is 25%, but in India it is close to 40%. Why this difference? So this is what I think we need to look into that, and this is more again because of our thin fat Indian or Indian phenotype concept, which is different. And you can see that 58% will have those who got a metabolic disorders. They have 58%. In fact, it is vice versa. If you can see that if you have metabolic. So next slide, you can realize if you have NAFLD, you are supposed to have metabolic disease as well. Rather, you can look into it in either way. And look at this pediatric population. It's almost 35% of the children are having fatty liver, and this is because in the last 8 years, which was obesity, which was about 0.2%, has gone to 3% in 8 years. And this is the problem we are facing. The children less than 5 years old, this is happening. Tomorrow I will have more details about that. That's the reason you can see that in pediatric population, you could see that there is so much of fatty liver. Now, if you look into that, 90% of the people who have fatty liver or MASLD are obese, number one. Number two, they will have about 70% of the people will have type 2 diabetes, because whenever you have a fatty liver, there is more increased or neoglucogenesis. Hepatic glucose output is extreme. Some of you are be wondering, when you do a blood test, fasting will be higher than postprandial, right? Very often you would have seen. Fasting is more than postprandial. This is because they have enough insulin to take care of the postprandial blood sugar, but the insulin resistance in the liver is so high, it produces more fat in that, so it produces more glucose, and that's why fasting blood glucose is totally contributed by hepatic glucose output. So this is very severe. So that is the reason you can see that. So type 2 diabetes is very high. Hypertension you can see in 70%. Again you see this triglyceride. In India, 83% of the people are having triglycerides, and metabolic syndrome in about 70%. You can see that, and the most important culprit, if you see, is the root cause, is the insulin resistance. What is insulin resistance? Simple. Insulin resistance is nothing but you have abdominal circumference increase, you have visceral adiposity, and this visceral adiposity increases the triglyceride influx into the circulation, and these triglycerides go and sit in the liver and cause fatty liver. As simple as that. So the insulin resistance syndrome is the main thing which causes the fatty liver. So fatty liver is because of insulin resistance, one of the victims of insulin resistance apart from vascular damage is liver as well. Now which can lead to cardiovascular disease. You can see that this is what's important. Cardiovascular disease, insulin resistance syndrome. Fatty liver is part of insulin resistance syndrome. So you can have increased cardiovascular disease. So that is the reason we should not ignore fatty liver. We need to look into fatty liver as well. And then cirrhosis, hepatocellular carcinoma, and mortality. Ultimately this will lead to that cirrhosis, but we don't see so often. But nowadays, whenever we say cirrhosis, we think it's an alcoholic. Whenever you take a history, they said, I never touched alcohol. Then why is it happening? Most likely fatty liver converted into some of the people where progresses very fast to cirrhosis of liver. Now when you look into the NFT, it is not just a fatty liver, you can see the stages of fatty liver. Now you can see that normal liver, you can see that on the right side of your screen, you can see that normal fatty liver, and then you have a steatosis or fatty liver, a simple fatty liver. You can see that without inflammation or hepatocyte ballooning. Deposition of fat is there, but there is no inflammation or ballooning of the hepatocyte is not there, right? Second, now then this is about most of the patients. Out of the 32% or something like that, 25% of the people are having this problem. About 1.5 to approximately 5% of the people will have steatohepatitis. That is steatosis. This is steatohepatitis, which is nothing but fatty liver with inflammation and hepatocyte ballooning, both are there. This is the intermediate stage. The next stage, if we don't intervene at this stage, they will go into fibrosis, and it is a non-reversible situation. And that is the reason we can see the cirrhosis of liver. Now, about India, you can see that, as I said, that you can divide actually fatty liver. You can look into the steatosis, which is SO. Steatosis is SO, and then fibrosis you can see that F. So that by doing a fibroscan, you can see both steatosis, which can be graded 0 to 3, and then you can see that you can grade it to 4. You can see that in India, in screening about 1,500 people, they found that 36% of the people are in the third stage. Quite a good number. So fibrosis, 70% are normal, but still 30% are going into fibrosis. This is what we have seen recently when we did the fibroscan in our clinic in the last 4 or 5 times or so. We screened about 600, 700 people. This is the same picture we have seen in my clinic as well. Now how do you evaluate? Why do you need to evaluate? You need to evaluate so that you will know how to go about and how to take it forward. So that is the reason. You can see that patients with pre-diabetes or type 2 diabetes, if your ALT, that is SGPT, is normal and ultrasound is normal, but still it does not mean that it doesn't have a fatty liver, but look into risk factors, higher risk factors, still they can have fatty liver. And this is long-standing diabetes for more than 10 years, and A1C is more than 8.5. Triglycerides, again you see that 250, and probably genes. So these are the various circumstances. You can see that in spite of having a normal ALT and normal ultrasound, you can still, if you have these risk factors, what you can see, you need to go for assessment of fibrosis. Now if you look into that, what happens is that if you have an ultrasound abnormality or liver enzymes are elevated, then we need to rule out other causes before going into stating that it's a diabetic fatty liver. So you will rule out. Okay, now you have to assess. I'll come back to you. How do you assess this fatty liver in the next few minutes or so? Now we can divide it as advanced fibrosis, intermediate, no advanced fibrosis, right? And then accordingly, if you have an advanced fibrosis, you have to refer to hepatologist without any hesitation. If intermediate, you can do a liver biopsy. If you find definite NASH, then you have to send to the hepatologist. Otherwise, absence of NASH, you can see that we need to go for periodic evaluation, at least once in a year. Probably we can do that. Now, the reason why this has happened, we are talking about in spite of having normal ALT and ultrasound, is that a normal ALT does not rule out NASH. Liver enzymes may be normal in 80% of the people who got a NASH. That's number one. Number two, whether you have normal ALT or abnormal ALT, the histopathology is the same. So you cannot differentiate. So this is another point what we need to look into that. Now, how do we score identifying? Very, very simple. I don't want to go to too many details. You just have a FIB score. You can download in your mobile phone the FIB score analyzer. Then you can download it, and you need to have only 4 parameters. That is age, SGPT, SGOT, and platelet count. You have these 4 things and put it into that, and you will get the score, FIB score. That's called as FIB 4 score. FIB 4 score, because 4 parameters, that's all. Suppose if you have a FIB score of 1.3 and less, it rules out any liver disease. Now it is more than 3.25. It is high probability of fibrosis, F3 or F4. And you have intermediate between, if you have 1.3 to 3.25, this is called intermediate disease. This is what we have seen. This is what we see here. So if we can score, we can see that we can differentiate between that. A very simple way of looking into this FIB score. Now we can do a fibroscan. It's a very simple thing, but very expensive equipment. It's a small one. I'm told that it costs about 1 crore of rupees. But the sponsors of the day are ready to do it for you in your clinic. They have a fibroscan machine. They will be doing to it free of cost also. And then that is one of the best things that we can have. It will be the stiffness of the liver, the fibrosis, and as well as the fatty content can be estimated, and you can score. That is S and F both can be scored. And then you can see that liver biopsy is a confirmative. The problem is that psychological disturbance, risk of bleeding, pain, infection, sampling variability, unless it is really mandatory, hepatologist says do a liver biopsy, don't do that. Now we got a fatty liver. We know that it has got so many problems, and it also leads to cardiovascular disease, and that is the main reason what we need to look into management of fatty liver. One of the most important thing is lifestyle modification, energy restriction, macronutrient composition. Remember Dr. Mohan was telling about the high carbohydrate intake. Reduce that carbohydrate intake, reduce the calories, increase the physical activity, reduce the alcohol content, and don't allow them to take sugary foods. Nothing but calorie restriction, physical activity, reduce the weight. Now this is what we have. This is what the advantage that we have. By just doing the lifestyle modification, if you reduce by 3% of the weight, steatosis improvement will be there. 5% ballooning inflammation will come down. 7% weight reduction, NASH resolution can happen. If it is more than 10% weight reduction, fibrosis regression and absence of fatty liver can happen. So you can see that again it is the obesity and the free fat is a reflection to that. And this is why, if you can see that in the Turner cycle, twin cycle hypothesis, for remission in diabetes, remember remission in diabetes, it is the hepatic fat that comes down is the only factor. Hepatic insulin resistance coming down by reducing 10% of the weight is responsible for remission, and skeletal muscle insulin sensitivity doesn't matter for remission. And this is how the liver is such a huge entity that we need to look into. Now look into that pharmacotherapy. I'll finish in next 3 to 4 minutes, sir. Please excuse me for 2 more minutes. So pharmacotherapy should be reserved for patients with NASH, particularly for those with significant fibrosis, F2 and higher, and patients with less severe disease but at a high risk of disease progression could also be candidates for treatment. Now, no drugs are, as of now, no drugs are approved, but still we can use. Metformin has got no say in the regression of the fat or fibrosis, but it is supposed to reduce a conversion of the fibrosis into hepatocellular carcinoma. That's one thing. Pioglitazone is one of the most powerful one which bring down the fatty liver. It improves the steatosis as well as the inflammation, but no anti-fibrotic effect. So you have to use it in an early stage. Now, DPP-4 inhibitors such as sitagliptin, vildagliptin are found okay, but they are not as good as what we see with pioglitazone. GLP-1 receptor analogs have been found to be having a very good, because it also reduces the waist circumference and also reduces the visceral fat, and indirectly it can give some betterment in vision. And of course, empagliflozin has shown SGLT inhibitor. So first one is pioglitazone, second thing is GLP-1 receptor analogs, third one is SGLT inhibitor. I think all the three products anyway we are using for type 2 diabetes, and so this may be very useful one. And most of the people use this ursodeoxycholic acid, right? Absolutely no use. Don't waste the money from our patients. It's of no use at all, except one study which is a small number. None of the studies have shown improvement in this. Now, coming to the hero of the day, that is the saroglitazar. This is the sponsors one, and I think Dr. Paneerselvam, our chairperson, has done a lot of work on that actually, saroglitazar. And it is nothing but saroglitazar is a dual PPAR agonist mechanism of action. That is, PPAR alpha is found in liver, kidney, heart, and muscle, and is implicated in the uptake and oxidation of fatty acids and lipoprotein metabolism. So it reduces the free fatty acids. And then PPAR gamma is mainly expressed in adipose tissue with beneficial effects of glucose homeostasis by increasing the insulin sensitivity and glucose disposal to prevent loss of beta cell mass in the pancreas. So it's got suppose you take a pioglitazone, it is only gamma, but this is alpha gamma, and several molecules have come like ragaglitazar, and so many things have come, about 3 or 4, because of the toxicity they have been withdrawn immediately. But this is one dual PPAR agonist mechanism which has been found to be safe and can be used. Sara means good glitazar. Glitazone is different. Glitazar is alpha and gamma together. It's a glitazar. So it has been approved for diabetic dyslipidemia. Look at this. Diabetic dyslipidemia in India. Okay, it is approved. And also in 2020 it is approved for non-alcoholic fatty disease, because it has got evidence to state that there is a very good improvement. Like for example, because of the gamma activity, you could see that there is improvement in insulin sensitivity and glucose metabolism. And you can see that if they have done a study in USA, about 104 people. What they could study is that the reduction in 40% in liver enzymes, and then reduction in fat by 10% by 55%, and more than 30% fat reduction in the liver in 40% of the people. This is very good result. And one more study done with a biopsy-driven study. You could see that this is done for 52 weeks, that's for more than 1 year. You could see that when you use saroglitazar, the NAFLD, the activity score or the fibrosis, comes down by 50%. That's a very good result. This is what we say, that nailing in the coffin. And now as far as the one more study which has come in about number of patients, about 112 from India, we can see from Eastern India. We can see that with and without diabetes, and they have put them on 52 weeks on saroglitazar. They have found, look at the fibrosis. Remember that we said that F2 to F3 is the most important time where we have to look into and do a proper therapy that we have to do. And these two, you can see that by using saroglitazar in every stage, F1 to F4, you can see the reduction in fibrosis by using saroglitazar. That's a very good sign. Now, the Indian National Association for Study of Liver, this one also like RSSD they have one in 2022 recommended saroglitazar and FLD treatment. At least you have to give it a minimum of 12 months for getting the result. And even in renal insufficiency, you can see that the PKPD does not get affected, and it can be given safely even in renal factor. And LAA, Lipid Association of India, RSSDI, and INASL have also all recommended. This is Indian recommendations are seen here. So friends, let me conclude to say that This is a, don't ignore the fatty liver, right? Those were the days when we didn't have much of study, about 25 years ago. Dr. Panisalam will be agreeing with me. If we send an ultrasound, almost everybody there is a fatty liver. Like, diastolic dysfunction, echocardiogram. Now we are realizing what they said is right. We are telling they are over-diagnosing. We used to discuss also they are over-diagnosing. But now, with all the knowledge that we have, the improvement, I think this is one condition we should not ignore. So let us not ignore and look into that. MASLD is a important factor that you need to look into that. It is associated with the cardiovascular risk factors, can increase the cardiovascular disease. Screening is very important, and also manage appropriately lifestyle modification and probably saroglitazar. And there are other drugs such as pioglitazone which can be used if necessary, can be used as well. Thank you for patient hearing.
Thank you, Dr. G. Vijay, and thank you,